and with the National Center for Medical Legal Partnership, and we're going to kick off today's session. First, I'm going to hand it over to Jen Yang, who's going to give us some of the ground rules around technology, and then she'll bounce it back to me. Jen, take it away.
Oh, no, Ellen, that's going to be me, but I've got that.
Sorry.
That's okay. Welcome, everybody. This is Marcella McGuire from CSH. We're all excited to have you on board. Just a couple of housekeeping announcements as we go through there. One is that, as you can see, that red dot is on your top right screen. That means we're recording, so that's exciting. We have a poll that is already up asking about where your health center or where your projects are in regard to Medicaid, et cetera. So please do that, and we'll get a sense of sort of where our audience is in regard to a number of these questions, et cetera. And let me see, what are my other notes? Please note that everyone is muted to reduce noise. If you have there's poll questions up there. How ready am I to dive into leveraging Medicaid today? So thank you all for answering that poll, and we'll get a sense of the audience today, which is really helpful to all of us presenting. Muted to reduce noise. If you need to talk, there should be a next to your name up here on the WebEx should be a microphone that's crossed out in red. Just click on that and you'll be able to join in there, et cetera. And then if you have any questions, please submit through the chat. There will be conversations happening there as well, and multiple conversations in multiple places. And know that we'll end going through all of the questions as we did last time, so folks will be able to have some dialogue both with our presenters as well as with each other and the faculty. I think that's all the details. Oh, one other question, make sure that when you are submitting any questions to the chat, you select participants and you select everyone rather than just going to the host, Jen Yang, or any of the other individual faculty. I think it helps everybody to see all of the questions our audience has here today, so our participants have today. It's not an audience, it's a group. So yeah, and with that, Alan, I think I will send this back to you.
Great, thanks, Marcella. Hi, everybody. Really excited to be with you today. We got some really wonderful content lined up for you. Today's faculty, kicking off with me, I'll be facilitating and emceeing today. We've got Michelle Jester and Marcella McGuire with us, and then we're featuring Nashia, Julie, and Angela from Michigan and Missouri PCAs, respectively. And then we've got some great volunteers. Thank you, participants who stepped up. This is about having a conversation, and there you have it, just so you can get a little visual on the team in front of the room, as it were. Next slide. Great. Obviously, we want to hear from you, and throughout the duration of the Learning Collaborative, and obviously through this webinar, it's one of the first instances. And just to give you a sense of the participation, we pulled the data. 76% of the registered organizations participated in last week's webinar. Some of them are downloading it and off hours if they couldn't participate. You can do the same. We had about half of you participating on Slack, and some of you came in just this week, and great, we want to honor that. Thank you. And then we had about 30% submitted homework, but we had some latecomers. We won't take points away. That submitted on Slack today, so thanks for doing that, and we'll visit that homework during the discussion portion of today's session. And then we had about 36% of you filling out surveys as of the 10th, and so hopefully we can bump up that response rate next time. Next slide.
Cool.
Okay, go ahead. Oh, thanks. This is a WebEx reminder, and I think Marcella covered how to activate the chat, et cetera. So don't hesitate to let us know if you're trying to get into the conversation. Last time we weren't quite on it with the chat, and somebody reached out to us on Slack, and so we were able to resolve the technical issue. So don't hesitate. Next slide. Okay, so today's session, big picture, is designed to hopefully, we got some wonderful big picture vision and architecture of some of this work, how financing social determinants of health and we got to hear from our partners at Missouri and Michigan PCA. And today's really about nuts and bolts. We're coming right down to the ground level about building an SDOH model that's powered for public investment. And then the second prong on that is strategies for engaging managed care and understanding and supporting those models and trends. And so let's make sure that we focus on trying to get to number 2 on that session, especially during our Kick the Tires session. And again, thanks to our participants who are going to be hopping in following the shares that are coming from Missouri and Michigan PCA. So next up, next slide, is our specific agenda here. We're going to hear first from Angela Herman-Nestor, and she's going to do, again, a deeper dive than she did last week into activities at Missouri PCA. We'll get to do some Q&A with Angela. I know some of you had some burning questions, and we just saved you like 5 emails because now you can ask Angela yourself either in the chat box or unmute yourself and hop in and ask questions. And same for our friends in Michigan, the PCA. Now she is back with us. And we also have Julie Katko, who's now at Cherry Health, and they're going to talk about the work that's happening in Michigan. So that's our agenda. And with that, I'm going to kick it right over to Angela if you're ready to go. We're already ahead of schedule, folks. Angela?
Okay. Thank you very much.
Take it away.
Okay. He's going to let me advance.
You know, if you're getting organized there, we can post our poll results so we can get a pulse on where everybody in the audience is. Jen, do you want to go and do that? We can see it.
And Jen, I'm not seeing the control to allow me to advance my slide.
Oh, God. Okay.
So it might be easier for you just to advance for me, Jen.
Angela, that's perfectly fine. And yes, the poll results should be up now on the right for everyone. In the meantime, Angela, we're going to, I'll move on to your slides.
Okay, next slide. Next slide.
I can't select.
Okay. I just wanted to, last week I just verbally shared some information about Missouri's health centers by the numbers. And so I just wanted to supply this as a reference so you'd have a sense of who our health centers are serving. And also just a reminder, Missouri was not a Medicaid expansion state. So that has some implications for some of our work here in Missouri. Next slide. So here in Missouri, we really are seeing our community health workers as a major strategy for advancing population health. And on this slide, it shows some of the key activities or ways that community health workers can really help advance population health. And you'll see at the center, the gray box, address social determinants of health. And yesterday at a training, one of our providers at our health center really challenged us to think of it not only, are you able to hear me?
Yep, we can hear you.
Okay. Not only as social determinants of health, but thinking about it as structural and social determinants of health, because sometimes there are folks that think if it's just a social determinant of health that someone can just, you know, has the option and can just take care of things, but structural could be the community that they grew up in and having lead in the water. You know, that's more of a structural versus a social, what we oftentimes think of as a social determinant of health. So I was challenged yesterday to really start to think about it not only as social determinants of health, but structural and social determinants of health. Next slide. So in Missouri, our funding is provided to our health centers by our Department of Social Services, and they actually contract with the PCA, and then we in turn contract with several of our health centers. This funding, the source of this funding pulls down a federal Medicaid match. So the patients that the health centers can work with are those that have Medicaid coverage. And so that is our patients that have fee-for-service Medicaid, managed Medicaid, or the dual eligible patients that have Medicaid and Medicare. We have 26 of our 29 health centers in the state that are participating in our community health worker program. And we have 50 community health workers providing services across the state. Next slide. So on this slide and the subsequent slide, I'm really going to this provides just kind of our broader overview of our program. And so for the purposes of today, I'm going to really focus in on the purpose because of our limited amount of time that we have. But really the main purpose for our community health worker program is really involving patient engagement in preventative chronic disease management and self-management services offered in the health center, connecting those patients with the care teams at the health center, connecting patients with the community-based services, also assessing and assisting patients with addressing their social and structural determinants of health, reduce potentially avoidable emergency room visits and those hospital admissions and readmissions for those ambulatory sensitive conditions. Because we are utilizing funding that's provided by our Medicaid agency, that a reduction in cost, primarily from those avoidable emergency room and readmissions for ambulatory sensitive conditions, is a very important piece of this. You see there some of our key outcomes, and then some of our core community health worker functions, really looking to empower and coach and really serve as that liaison for the patient, between the patient and the clinical team whenever the patient is out in the world living their lives, also connecting with those community partners, and helping patients really navigate our very complex health system, as well as meeting their needs in their communities. Next slide. This just shows some of our common settings for our community health worker encounters, some of our key referrals, and our data collection that we're doing for the program. Next slide. So the next several slides are going to show our templates and our reporting that we're doing for the program. So I've showed on the last two slides the overview of our program, the high-level overview of our program. So you might be asking yourself, okay, that's all fine and good, but how are health centers actually implementing it? And health centers have the opportunity to submit a work plan strategy that really is how they are telling us how they are going to accomplish the purposes of the program and the outcomes of the program. So this is where the health centers really get to have their input and have some control over what's happening with the program within their health center. We do have a set of required strategies as well as some optional strategies. So just for example, on this strategy one, we do require that our health centers, community health workers go through one of the formal community health worker training programs in our state that are offered at some of our community colleges. And so if the health center has a community health worker that's not been through one of those programs, then this first strategy is required. If they have everyone trained, they don't have to do this one. Strategies 2 through 6, they are required to complete those strategies. So it's how are they going to implement the prepare tool? How are they going to track the interventions and encounters? How are they going to engage patients in their care? Next slide, please. So one of the things that we added this year was we wanted to start to track, because we're on our nearing the end of our third year of implementation for the program. And so this year we added the requirement to track some clinical, some of the ECQMs that are the same ECQMs, electronic clinical quality measures that are the same ones as UDS. And we asked the health centers to select one clinical measure or ECQM out of the 3 categories. So we have 3 categories here. And so then they were going to tell us, you know, what they told us some of their baseline numbers. Some of them are creating cohorts so they can track performance on these measures for the community health workers, patients that the community health workers serve. And then I'll just go quickly. Strategy 6 is really taking a look at how they're going to impact those avoidable emergency rooms and hospital admissions and readmissions. Next slide. This is just on that strategy 5. These are the measures that our various health centers selected. So we did have health centers select measures there's at least some health centers looking at every one of the measures that we included. So we're pretty excited about, this is our first year, so we're not sure what this is going to tell us yet. But some of the early data is looking like having a community health worker is starting to help impact and improve some of these clinical measures in the ECQM. Next slide. And then these are some of the optional. So the health centers are required to select at least one of the optional measures. So for some of our health centers, they're really focusing in on doing some additional screening for substance use disorder. And so in Missouri, we use experts for our screening. We're very fortunate that we've had quite a bit of work with our Department of Mental Health and Missouri Institute of Mental Health over the years. So we have a fairly robust program here in Missouri. So they could opt to do a little more work around that. They could focus on prenatal patients, or they could focus in on some additional training or continuing education for their community health workers. Next slide, please. So for the program, so that was basically the health center tells us at the beginning of the year what is their plan for the program and for the funding. And then on a quarterly basis, the health centers submit a variety of reports to us. So they do submit a qualitative report that identifies patient stories, barriers, success, training, and technical assistance needs of the health center. So we built in for our qualitative report, it's so important for our Medicaid agency, those patient stories. And we've been told by our Medicaid agency, they have actually compiled some of those patient stories. They've shared them with our governor's office as well as the legislature. And we've also pulled some of those together in a report for our state officials. So that has been, building that in is real key so that you have those patient stories, because that really does make a difference when you're trying to advocate for additional funding or continuing your funding. We also are looking at, we utilize the Prepare for our social determinants of health assessment. And we're also looking at our CHW encounters and referrals to community-based organizations. So I'll go ahead and go to the next set of slides because I have examples. So this is our qualitative report. It's just a really simple report, and many of our health centers attach multiple success stories to the qualitative report. So it's just been phenomenal. It also helps us identify what areas are they really struggling in their area. So the referral to various community resources. And so we're starting to look to see if in various regions, if there's some commonalities, so we can see if we can help the health centers maybe work together in that area to address some of those needs. And then for us, an important key piece was integrating the community health worker into the care team, because we really feel like that is so critical to the success. And also, as we move to value-based care in our state, the community health workers are going to be a real important piece of that, because they're going to be that key patient engagement, so that We can get patients engaged in coming into the health center so we can close care gaps, because if patients don't come in, we can't close care gaps. We can't help patients overcome some of those barriers to coming to see us and being successful in managing their very complex chronic conditions and their the very complex things that they encounter in their lives. I mean, it's just amazing. Some of these success stories, I just am in awe of how patients really persevere under just the most adverse circumstances. So it's very rewarding when our community health workers have been a piece of helping that patient really overcome some of those barriers. Next slide, please. So this is, this starts our prepare in our community health worker intervention and encounters. So we do have them report average number of social determinants of health categories. And one of the things that we are exploring in Missouri is once we have good social determinants of health data, we are hopeful that we can start to incorporate that into our risk algorithm that we're utilizing. We do utilize Azara Derives as our population health management tool, so we have worked with them on this, and I have a little bit more information about that in some subsequent slides. So next slide, please. And so this just starts through on our CHW encounters and interventions, and this one has quite a bit more detail because we designed this so that if we get to the point where our Medicaid agency is allowing billing for community health worker services, we wanted to have some information about what is, how long are these encounters? What are the settings for these encounters? What is the contact type? Is it in person? Is it over the phone, secure messaging, secure texting? So that we would have a sense as our Medicaid agency developed that reimbursement, that it would be based on real live information versus them arbitrarily deciding the unit of measurement would be 10 minutes and it would be for X number of dollars in this setting, when we know that that might not have worked well for our health center. So we're collecting this information and sharing it with our Medicaid agency. And even though our community health worker state plan amendment didn't get enough traction this legislative session, there's still a large group of us that are working so that we're going to be doing some advocacy over the summer and some work so that we're ready for the next legislative session next January. Next slide, please. And so this is just what is the presenting issue. So we also could get a sense of what patients were presenting with for this community health worker. Next slide, please. And then this year we added, we wanted to start collecting some information about the referrals that community health workers were making to outside social service organizations within their community. So this just kind of gives you a sense. We wanted to know what referrals they were making and then how many of those were successful, that the patient was actually able to get an appointment or get some assistance with some of these various areas. Next slide, please. Just wanted to remind the health centers that are on the call, if you have NCQA, patient centered medical home recognition, they do now require assessing and addressing social determinants of health in some of the core and elective competencies. In Missouri, we're utilizing Prepare to help our health centers be able to take advantage of some of that. And also with our Azara Derives, the social determinants of health information is available in our pre-visit planning report, our care management passport, social determinants of health registry, a dashboard, and we now have a couple of measures. So not only are we doing the assessment, but then it can be used at the point of care by the care team. Next slide. This is just kind of an overview of the things that are available in Azara Drives. I know there are quite a few health centers and PCAs across the country that are using Azara as their tool. So I just wanted to share some of the information. So if you're utilizing Azara, this information would be pertinent to you. Next slide. And then these are the 8 categories. So Azara has divided the prepare data elements into 8 categories. So this slide and then the next slide has them listed. And then next slide. This is some feedback that we received from our community health workers on their experience with Prepare. We were able to do that last year when we had our first community health worker peer learning network. So they really found that it was extremely helpful. It helped to guide the conversations, helped to build those trusting relationships. And they also gave us some improvement ideas for the Prepare going forward. Next slide. Here is my contact information. If you need to get in contact with me, email is probably the best, your best route. And just let me know that you heard me present on the Social Determinants of Health Academy, and then whatever your question might be. And the next slide should be the question slide.
Great. Thanks, Angela. Let's take a pause here and a round of applause virtually. Angela, for really very concrete and helpful information. I know we had one question come in over the chat box that I think a group conscience can respond to. There was a question about the Prepare tool, and it's implemented across all CHCs in the program, right? And is that a mandate that came from the PCA, or I think the question was DSS. I'm not sure what that means, but
that's our Department of Social Services. And so we were fortunate that we were able to work collaboratively with our Department of Social Services, which is where Medicaid is housed in Missouri, on the development of what tool we would utilize. And the PCA Board of Directors several years ago decided that the tool that we would utilize in Missouri was the Prepare tool. So we were able, when this funding came along, it allowed us to utilize the Prepare tool, and then we've worked with Azara to get that improvements on the reporting. So it was a requirement within the contract, but we were able to work with our Medicaid folks. They were in agreement that it looked like a good tool to be able to track social determinants of health. So that's how that transpired.
Great, thanks. So I'm looking for some questions in the chat box for Angela, because I know there were some that were happening when she presented last week. And so as we're waiting there, Angela, I wonder if you could share, because what you're talking about is pretty well developed compared to where some folks on the call are, and we're going to hear from some of our people who are earlier on. Do you have any advice? A lot of what your the work that you've done is very much in anticipation of the future. So, you know, what your advice might be for a single health center that is trying to pull together some data and put down a vision like what you have been able to accomplish in Missouri.
So I think
starting, yeah, go ahead.
In the beginning, it's just real important to develop where do you want to go? You know, what is your kind of goal? You know, for us in Missouri, it was important. We wanted to have more than just our anecdotal stories about what the needs of our patients were and what they were encountering. And so the Prepare tool for us in Missouri has helped us start to have some numbers to go with the anecdotal stories that are very important. Stories, personal stories are always very important, but our state legislature wants numbers. It's just the nature of the group. You know, their stories, yeah, those are great, but what are the numbers? How are you going to help save me dollars? How is this going to improve the performance? The Medicaid plans want to know, how is this going to get more patients in and you close more care gaps? Working with your team to determine what is important. We also found in Missouri it was real important to involve the outreach and enrollment and those that are working with enabling services, because those are the folks that are most connected with those needs for your patients at the health center. And also looking to see what community organizations or groups are already starting to look at, you know, transportation or food insecurity, and just kind of starting out looking at what resources are out there, so that as you identify the needs, that you have some resources to help the patients. You also have, we found in Missouri, starting with a smaller subset of our patient population versus the whole patient population, helped health centers really learn how to do this, and then they expanded to other populations. So starting smaller, so it's more manageable, kind of the concept of PDSAs. You don't start with your entire, you know, your quality improvement. You don't start with every single provider or every single patient, but starting smaller. And don't let perfection be the enemy of good. So you're going to make some mistakes, but you need to start. And if you just plan forever and never kind of pull the trigger on starting that implementation because you're afraid you haven't planned or got everything in place, that's okay, because you will develop it over time. So we've been doing this work for several years, and we're still doing different pieces of it and still further developing it. Someone asked, Ruben asked, who developed the reporting tools. I was the primary developer of the reporting tools. So we are hopeful that as we get further along and more of our health centers are documenting the CHW encounters into structured fields in the EMR, we can get that information into drives and have that mirroring of the social determinants of health assessment using Prepare, and then have the CHW encounter information, and then perhaps in the future some of the referrals to the social service agencies.
Great, thank you, Angela, and especially the pep talk, right? I think we all need that, because this work isn't a one and done. So thanks for that, and Angela's going to be available for about another 15 minutes or so. She has to step off early, so if you have a question, you want to pose it in the chat box, feel free, or follow up with her. Thanks for sharing your contact information. And now we're going to go to our friends in Michigan, and Nashia is going to kick it off and give us a quick review from last week, and then we're going to get to hear from Julie Tatko. So take it away, Nashia.
Thank you. So I just want to apologize in advance. You'll hear some background music playing. I'm actually sitting in the hotel lobby. I wanted to make sure I was able to join this call for at least a half an hour and share some quick updates. So in terms of what we spoke about last week, the Michigan Primary Care Association, I've included just brief information regarding how many health centers we have and the mission and vision. And in terms of some of the work that Angela and them are doing over at their PCA, it was actually really interesting to hear how they went about implementing the Prepare tool and making sure that there was integration going on. I know we've had some interesting conversations with our health centers as we've done some of the work to get them on the Prepare tool and getting people involved in collecting a lot of this SDOH data. And I'm actually really excited to have Julie with us because she was at the PCA when we started this work. And the fact that she transitioned over to a health center who's able to provide and do a lot of this work specifically at their health center has been really important for us because we get to hear that feedback from the health center perspective as well. So just a couple of quick updates from what we talked about last week. So the state is doing the SIM model, which is incorporating a lot of that population health work, and so we have several different shires throughout the state that's also collecting population health data. And in addition to that, we have a handful of health centers that are implementing the Prepare tool, and we're actually, and I believe I mentioned this last week, but several of us within the PCA are going through their Train the Trainer Academy, and so we're able to continue the work that we're doing with these health centers in terms of providing the training and the technical assistance to ensure that the data that they're able to collect is something that they're able to further establish and provide enabling services with. And so part of that conversation at the PCA has been, what does the risk stratification look like, and how can we further provide that support to our health centers? So similar to Angela, we are also using Azara Drives as the management tool on our end, and that conversation has also continued with some of our data folks at the PCA, and we're able to post some of that information and take a look at it on our end. And so we will be a part of the webinar that's going to take place with APCHO, I believe on the 25th, and so we'll be reviewing some of the SDOH data we were able to collect, and we'll actually have one of our health centers join and talk about their workflow, and then also post some of that information from Azara and talk through what it looks like on our end and what we're able to do with it. So if any of you are able to join, I'm tossing in a quick plug here, we would love to have you on that webinar as well. So without further ado, I will go ahead and hand it over to Julie.
Great, thanks, Masha. Julie?
Hi, good afternoon, everyone. Can you all hear me?
Yes, we can. Take it away.
Okay, great. So let me just give a quick introduction to myself. I'm Julie Tatko, and I'm the Chief Operations Officer at Cherry Health. And if you go to the next slide, I'll give you a brief overview before I get into our topic about who we are as a health center. Cherry Health is the largest FQHC in Michigan, and we are serving patients across 7 counties. We have 24 sites, 68,000 patients, so that gives you a sense of our size and breadth. And we're offering comprehensive primary care services like many of our sister FQHCs, medical, dental, vision, behavioral health, and we have a real emphasis on substance use disorder treatment and targeted case management. So we're doing a lot. What I thought would be most helpful for the conversation that you all are having and the learning that's taking place here would be to talk to you about how our model for addressing social determinants of health has evolved over time, along with how payment has evolved over time. So if you will go ahead and go to the next slide. I tried to lay it out in a way that I can talk through it. And there's so much to talk about on this topic, and so I'm so appreciative to get to join and hear Angela talk about what's going on in Missouri and the program that they put together there. It is a little bit different here in Michigan, and I know Nasha had the opportunity to talk about that last week, but we're not quite as streamlined. So what we present here is an example of how we as a health center have been able to move forward in addressing social determinants of health with our patients, but we don't have quite the same leverage and similarity or standardization across the state. Quite a few years ago, long before I joined Cherry Health, we did our best to meet the social determinants needs of our patients, and one of the ways that we did that, I think that served as a building block for where we are today, are through key partnerships. So some examples of those key partnerships that I think paved the way for us to start to take this work on ourselves because we recognize the value of it was a partnership with a local organization called HealthNet of West Michigan, and they identified gaps in healthcare organizations and other service organizations, and they hired CHWs that we could refer our patients to for further assistance. they were, over time, able to get support from the Medicaid health plans that served our area to help pay for those CHW services, but that was and has been a very key partnership for us and a support for our patients. Another key partnership was a network that developed specifically to support asthma. So it was the asthma network, and whenever we had a pediatric patient that needed additional support in that area, we could refer out to make sure those social determinants of health were addressed. And like all FQHCs, we have many partnerships in place for referrals, whether that's knowing our local housing resources or food resources or whatever it may be. But that really started as our starting point for addressing social determinants of health. And then we started to get involved about, I'd say 7 to 9 years ago, with starting to look at how do we fund programs in-house that are specifically serving our patients. So we have had private foundation grants. We've had state grants that have supported our own employees to be able to, for us to be able to hire community health workers. We were a part of Michigan's large-scale community health worker initiative that implemented Prepare over 2014 to 2016. We have a maternal infant health program, which is a state-funded program that funds home visiting, including nursing and social work support. It also has a CHW component that we've been able to wrap in using Healthy Start funds from HRSA. And then we also, several years ago, developed a partnership with our local legal aid organization and started a medical legal partnership, which they really launched and got off the ground through grants on their side, and then we've had a mutual commitment to having one of their attorneys on site to be able to meet the need of our patients in that for legal needs. So this is all different ways that we just tried to be smart about pulling in the resources and models that were existing and available to meet the needs of our patients. And as we come into this third column here, we still kept doing all of these things. We still have our key partnerships. We've tried to renew community health worker grants as they have ended. We still have our maternal infant health program and MLP. But we had the opportunity to join in with the two large-scale Medicaid waiver demonstrations in Michigan. The first is primary care health homes, and these are two that Nasha may have talked about last week. Our primary care health homes in Michigan is a lot like what Missouri is implemented. In fact, we learned a lot from Missouri as we were putting it in place and designing Michigan's. It has allowed us to have it's not exactly a per member per month payment, but it's that kind of model where they're giving us the dollars that we need in order to be able to provide care management and wraparound support for patients. The state innovation model, our participation in that has been similar. It's allowed us to be able to get care coordination payment through Medicaid, and these waiver demonstrations are all directly with our state Medicaid office. And it's allowed us to get that care coordination payment, start to hire nurse care managers and CHWs and use them as a team to support and address social determinants of health. And now in this last column that I put here, the Medicaid managed care, this is our newest territory. So we are a managed care state here in Michigan. We have, I think, 10 or 11 managed care organizations that Medicaid contracts with throughout the state, which is a lot to handle at the health center level. We contract with, I think, about 6 different Medicaid health plans here in our region in West Michigan. And as this state innovation model has moved out of a waiver demonstration, because that waiver is ending, we are starting to see them turn it over to the state is turning that model over to the Medicaid managed care organizations and requiring them to contract with health centers and incorporate these same same care coordination supports, and addressing social determinants of health. So it's all evolved. Really the only one of these that's going away are the waiver demonstrations, and we're starting to move more into seeing the social determinants of health be captured and addressed within that Medicaid managed care world. So that was a mouthful. I apologize. It's a lot to talk through. What I wanted to do before we move into a question and answer period was to give you an example of a value-based contract that a managed care health plan just brought to us actually within the last 2 weeks. So this is really an evolving landscape for us. We have value-based contracts with our Medicaid health plans. They're not centered around this same concept, but they're pay-for-performance contracts. So we've been very successful in having conversations with our largest Medicaid health plan to say, you know, here are all the quality initiatives, here's the progress that we've made, and we want your support to be able to do this better. How can we get incentives and things like that? What this value-based contract that is evolving from the state innovation model incorporates is it's bundling the care management and coordination services with the social determinants of health, and it also includes these targets of quality measures and inappropriate ED utilization. So I'm just going to walk through this. I'll slow down just a little bit, and I'll walk through this, and then I'm going to tell you what I like and don't like about the contract, because I think it's important for us as health centers to come to be thoughtful when these opportunities come our way, but also to be proactive when we sit down with a health plan to talk about what our future could look like that is a win from the health plan's perspective and a win from our perspective to support the work that we're doing with patients. So in this value-based contract example, they wanted, it was based on eligibility for our PCPs. So they looked at the PCPs working at Cherry Health, and they said, you know, we want to identify PCPs that have more than 50 plan members from this specific plan. So they identified, they identified 2 of our sites that they wanted to start working with, and you know, we had 3 providers at one site that had 50 plan members and 2 at the other site. This contract will focus on care management and coordination services. It includes a requirement that we assess the social determinants of health, that we report what the reporting is through claims, so they want us to use Z codes. And they want us to then have some kind of documentation of how we're making linkages and closing the loop and doing the work to address the needs that we find. And then what they're going to be tracking as well is they have quality measures from HEDIS that they've identified, and then looking at our baseline, they want us to maintain or improve inappropriate ED utilization, and that's defined by a series of codes that they've identified. So what does this allow us to do? How does that, what's the incentive for us to participate? They're going to open us up to being able to utilize care management codes. So they have G codes and CPT codes that now we can bill for, which we couldn't bill for with this plan previously. And then they're offering us a per member per month payment for meeting the quality measures. And we get the $2 PMPM if we meet 75th% of the target, and $4 if we meet 90th percentile of the target. And then bundled with that, we have to maintain or improve the inappropriate ED utilization. So what struck us was that, you know, just right off, the baseline data that they showed us, we actually had no inappropriate ED utilization at one of the sites. So we were at 0. And so the way that they structured this contract, if we had one person that went to the emergency room for one of these reasons, we were ineligible for any of the per member per month payment. So, you know, it was like we walked through this contract and we just pointed out all of the challenges from our end of this being a useful reimbursement mechanism. The other thing that jumped out to us was that we have a lot of part-time primary care providers, and that's one of the successful recruitment tools that we've had is being able to offer different is to pull providers in to work different schedules. So as a clinic site, we may have a couple hundred members, but they're spread across providers in such a way that they wouldn't be eligible. And then we also commented to them that we're not currently billing and documenting through Z codes, and we actually didn't think that the Z codes that they picked were very informative. They weren't actionable, and we would like to be able to report data in ways that were more aligned with how we have been doing it and more informative. So this is where we really partner and rely with the state, our Michigan Primary Care Association, to be our advocate out in the front to help make sense of these contracts. So what we want is with having 10 Medicaid health plans out there, for the message to be out on what's reasonable to expect a health plan to partner on, and to be setting the stage for that, so that we're doing consistent messaging across the board. We're hopeful that this will move in the right direction. I think a lot of the feedback we gave other healthcare organizations that they had pitched it to had said the same thing. But again, it's a process. So that's why I'm putting that one forward as an example. I wanted to mention just two other things before I rest and let you all answer any questions that you have. And that is that like in Missouri, some of the keys to our success with rolling out and evolving over our different models of social determinants of health was to get to the point where we did adopt a standardized social determinants of health assessment tool. We had used Prepare, but then we became part of a larger regional social determinants of health assessment initiative, which is the Accountable Health Communities Initiative, which required us to adopt a different tool. And we didn't let that be a step backward for us. The state innovation model actually even requires a different tool on top of that. Instead, we pulled them together. We streamlined it as best we could. We even identified where what the markers would be within that tool for a referral to medical legal partnership, because that was really important to us. And so we took that approach, and we took our own initiative to interface it with our EHR, since we didn't have that option to adopt a tool that had already been developed. And then the other thing I just want to touch back on that Angela said was we have ended up taking a care management approach to social determinants of health, which was shaped by these waiver demonstrations that we were a part of, that makes a team of our nurse care manager and community health worker. But we've also taken the approach of cross-training staff whenever possible, so that our front desk staff are also engaged in in administering the social determinants of health assessment tool, or providing resources when that tool comes back fairly low risk. We have utilized our AmeriCorps program so that our members are trained, our AmeriCorps members are trained to also be involved in this process, and our outreach and enrollment staff. And I'm gonna pause there and turn it back and see if there's any questions or comments.
Thank you so much for that debrief, Julie. again, we will open up everyone for conversation. Please feel free to continue chatting everything in. If you would like to ask your question out loud, you can unmute yourself by pressing *6, or if you need any technical difficulty, please chat it into the message. I don't believe we have any questions that came in so far. So this is as helpful as much as everyone participates.
Hello?
Hello, Ellen.
Ellen.
Go ahead.
Hi, can you hear me? This is Ellen.
We can hear you now. You're good.
Oh, okay. I was chatting along there, everybody. Sorry about that. So I had a great opener there. Thanks for jumping in, Jen. I appreciate it. So I think we'd love to hear from Tiffany. Julie, thanks again for your really great bridging comments about kind of from soup to nuts. So Tiffany, do you want to unmute yourself and just say a little bit about who you are? We can click to your slide here, and then we'll be teeing up to hear from Ruben after you. And thanks to each of you for stepping up when we asked for participant volunteers. So if you want to just take a minute, Tiffany, and if you could, Jen, go to the next slide, that would be great. Oh, we had a poll too. I forgot about our poll. Maybe you can put the poll up in the chat on the side there, and folks can.
Yep, so I'm going to open up the poll, and then yes, and I'll advance the slides so while people are answering, we can continue on with the conversation.
Great. Okay. Now we're going to kick our tires, and I appreciate again California and Texas and maybe even Seattle that's going to hop in with us. So Tiffany, come on down to the front of the class. Are you on
Can
now?
you hear me okay?
Yep, absolutely.
Okay. Great. So my name's Tiffany Swarthout. I am with Tulare County. We're in Central California in a very, what in California is considered a rural area, but in most of the country, probably a suburban area. And it have high rates of poverty and things along those lines. I am with the county Health and Human Services Agency. So within our agency, we have a federally qualified healthcare center lookalike. So we do not receive any federal funding for our healthcare center. And being part of the county definitely has its advantages. We have what is nationally known as SNAP within our agency, women, infants, and children, and then in California, Medi-Cal eligibility workers. So we, for our clinic, our healthcare center, we definitely have the capacity to implement some of these enabling services on site. That's not being done across the board right now. We do have SNAP and eligibility determination assistance for Medicaid on site to ensure access to insurance and food for our patients. We are currently looking at integrating the Women, Infant, and Children program into our healthcare center. But as a county employee and someone who cares about the community as a whole, I volunteered to be part of this academy to get a better idea of how we can market our enabling services to address social determinants of health in the FQHCs in our county. And so that's the challenge. We don't have a lot of collaboration going on across the federally qualified healthcare centers. So that's a gap that I would like to begin to address as a county employee, not specifically as an employee of the FQHC. So this academy is providing me those insights about what our partners may like to see. And then again, the opportunity that I have is once we implement a tool to begin to gather data on the social determinants of health, we have a lot of these programs. They talked about the maternal child in one of the previous sessions, or presenters talked about the maternal and infant program, and that's within our public health branch. That is definitely something that we could make some type of connection with our clinic to start offering, you know, 1 day a month or 1 day a week where they are out there offering those services. But it's not something that our agency has looked at in the past, and we're really at that point where we're trying to progress and gather data on what the needs of our patients are rather than assuming them, and making decisions based off of data rather than assumptions.
Great.
So,
thanks, Tiffany.
Thank you.
Yeah, it's great to hear you. I didn't know did you have another comment there, or?
Oh, I was just gonna say again that, like, we aren't at the point where we have implemented anything that's gathering data on the social determinants of health. So a lot of my questions are around, like, what is happening? What is the most effective tool? So I'm open to hearing anyone's opinions on those things through Slack or through an email. That would be helpful for me to progress my agency forward.
Great. Thanks, Tiffany. I appreciate you stepping in, and appreciate the insights and the opportunities to start building and make some of those partnerships real. So other comments or questions? And we can move to our friend Ruben, who's in Texas. Next slide. Ruben's going to talk about what's happening at Su Clinica in Texas. Is that right?
Hello.
Waiting for you. Oh, there you are. Great. Take it away, Ruben. Yep.
Wonderful. So yes, I am the Social Services Director here at Su Clinica. And so we're going to be talking about how we kind of started working with social determinants of health. We do use the prepared tool. So if we could go to the next slide. So when we started, I presented and provided social determinants of health orientation to our board of directors. It was determined data would be collected from our adult population. We then moved to collect data from other departments, including women's health, pediatrics, dental, behavioral wellness. So far, we've just been trying to get it right with our adult population. So we haven't moved forward with any of the other departments as of yet. And so I'll get into some of those other things here later when we talk about lessons learned and how we may be shifting that and getting a more focused approach to our population that we're obtaining social determinants of health data on. So it was decided that nursing staff and social workers would be involved in this process. I went ahead and provided orientation and training. We involved social workers, nursing supervisors, medical assistants, and providers on completing the prepared social determinants of health assessments for their respective roles. And so we began to roll out and collect data November 2017. Next slide. So our process or our workflow, our nursing staff and medical assistants ask 5 social determinants of health screening questions. And those are housing situation, worried about losing your housing, unable to get food, utilities, medicine, or healthcare when it was really needed, lack of transportation, and how often do you see or talk to people you care or feel close to. So if any of those questions get a positive response for a need, then the provider goes ahead and reviews that and determines if a social worker referral is needed. And a lot of times they are. And so then that will be created, and our social worker will then interview the patient and do the complete social determinants of health assessment. Next slide. So I conducted a progress assessment June 2018, and we found that some SDOH questions were not being asked by nursing staff. They were omitted. And so we formulated a corrective action plan. I attended the nurses' daily huddle and informed them of the findings and listened to their responses. Based on their discussion and the responses, the recommendation was made to put posters with the SDOH questions and place them in the treatment room to ensure that they were being reminded to ask question each time they screened a patient. So that really helped. The next slide. So what did we learn? Well, you know, we see 32 to 34,000 unique users in our clinics. We have 4 clinics, community health centers. We are an FQHC. And so we have a designation of a patient care medical home. And so some of these opportunities were missed. We didn't capture every opportunity we had to collect the SDOH data. And we noticed that the nursing staff did not have computers with them whenever they went into the treatment rooms. And so that may lead to inaccurate information being documented as well. We also did note, though, when the referral was made to the social worker or case manager that it was done completely, and so a full assessment data was captured. So if you go to the next slide, I'm not sure if that's my last slide. Yeah, so moving forward, in listening to the discussion we had last week, it was mentioned that social determinants of health assessments were completed on high-risk patient population, and again, I'm hearing that. And so I'm really thinking about focusing our efforts. I think that that would be a much better way to approach it. And so that is one of the things that I'm taking back to our team. It has been a learning experience, and I feel at times where, you know, will we ever get to where we need to be? But I love someone's quote here talking about, don't let perfection be the enemy of the good. And so I really am taking that to heart, and we will continue moving forward with SDOH. I really believe in it. And so I'm looking forward to continuing to learn from you all, and I appreciate all the feedback. Thanks.
Great. Thank you so much, Ruben, for sharing that. And I just, again, virtual round of applause for you and Tiffany for stepping in and sharing where you're at. And I wonder if you could, you know, having listened to our faculty in Michigan and in Missouri, and just offer a couple of reflections on, you know, what you heard, agree with enemy of the perfect and the good, or whatever the saying is.
Sure,
I agree with it.
Sure.
If you want to, you know, what landed with you
what I really am interested. What I'm really am interested in is the community health workers and involving them currently. Like I mentioned in our workflow, we have our social workers and our nursing staff involved, but I really do believe if we could get our community health workers involved, that would be a plus for us moving forward. And then also I'm very interested about funding, because you know, we need individuals to assist, and so if there is funding resources out there that we may tap into. I understood there's a HRSA grant that allowed community health workers, you know, funding. That would be something for us to look into. So learning a lot and very impressed with everyone's work.
Thanks, Ruben. So I'm going to put the call out for folks to weigh in the chat box or here. And Ruben, you know, you're in the hot seat, but we have some friends who submitted homework that might want to comment as well. Leah Yetter and Amy and her team from the PCA in Nebraska. To talk a little bit about, we'd love to hear from you if any of you are having conversations with MCOs. I'm sure the PCA in Nebraska is, but I don't know if that's a conversation that you've ever had in your role, Ruben, or if there's anyone else on the line who, you know, has a relationship with an MCO and what that looks like, especially given Julie's comments and insights, right, about their conversations, what that looks like. So I don't know, Ruben, start with you because you're unmuted.
Oh, I'm sorry. Can you hear me?
Go ahead.
Yep,
So
absolutely.
yes, I did hear that, and I am interested in reaching out to some of the MCOs. However, we're not there yet. As you know, maybe you don't know, but Texas is a non-Medicaid expansion state, and so that plays a part, regarding dollars and how we spend those and so forth. But I really do believe with some of what has been introduced here today, if we have the data and we have the structure, which I'm hoping, we can all implement and learn from, that may become a reality. And so I really do believe that is where we should be shifting our efforts to, is to gathering this data and making it available so that we have validity to requesting payment for these type of services, because it is extremely important. So that's just my biggest takeaway here. So I'm going to begin working to see and investigating as to how we can make those connections and get this thing going.
Great. Thanks, Ruben. I wonder if I can call if Tabby Sands is also on the call. She's in Texas also and submitted homework and was talking about nutritional needs, and we've heard some of you comment, both the PCA speakers and others commenting on nutritional needs. So I don't know, Tabby, if you're on and with us, and if you want to share any reflections or insights, anything concretizing for you. Tabby? Somebody's unmuted there. Okay. Great. I know also that we had reached out to our friends in Seattle, that fairly large FQHC at ICHS, and I don't know if anybody was able to hop in. I know you were having some technical issues. If you want to tell us a little bit about what you're doing and your work around SDOH, and what phase would you say? I thought Julie had her slide was really terrific about the sort of no cost into grants, and I can't remember the exact buckets there, but the sort of progression of sustainable funding for SDOH and interventions. And so I didn't know if, oh, thank you so much. There you go. No cost private and state grants towards Medicaid waiver demonstrations and Medicaid managed care. If the Seattle team, if anybody was, wanted to weigh in there and really open it up to comment about where you're at in this evolving model and payment for SDOH. And really anyone, I know we've got some folks from New York who were, so I'm going to pause for a moment and see if somebody wants to *6 it and hop on in. Because your peers want to hear from you. Hello? Seattle? Okay. So we keep going. Now, and I'm a lawyer by training. They call it the Socratic method. If anybody's ever seen The Paper Chase, you know you have to call on people. So hopefully it's not as painful as it is in that movie. But just trying to look through our homework here. I think Amy Goines also had submitted some homework there. And I know Leah Yetter, if you wanted to hop in from North Carolina, lots of action happening there. If Leah wanted to hop in and tell us sort of what you're getting out of this conversation and what your next steps are. Anybody need help unmuting? Great. All right, Leah, come on in. I see you. You're in. Come on down. Great.
I'm very far behind y'all. Obviously, we're not in a Medicaid managed care state yet, but we're there, and we're not an expansion either. So we have plans, but we aren't there yet. So
Can you say where you are? Say where you are, Leah, and where you're from.
North Carolina.
Yep.
Sorry.
Yep.
North Carolina. I'm in the western part of North Carolina, and I work in a very rural county, just outside of a larger urban area. And I'm in an MLP, so I am a health advocate in the health centers. So I work for the legal services, but I work in the health centers in collaboration with the health centers. So I've been there just for a year, and we, have a relationship with the health centers. But a lot of the things that you're all talking about, as far as gathering data and kind of finding, picking out populations that could be helped based on, social determinants of health. We didn't really do that in advance, so I am trying to figure out how to collect data and maybe to find out if there are any particular cohorts that I should be focused on, or if I just move forward with the referrals that I'm getting and collect the data on that. So it's early in the process. I work with all the different social service agencies and resources in the county, but again, like I said, this is a very rural county. There's about 20,000 people in the entire county. So it's really
okay.
And the adjacent urban area, we can access resources, but people prefer not to have to go into the bigger city. So just kind of building that network and working on data, and really trying to get the health center to understand social determinants of health and how to identify them and when to refer and that kind of thing. So I am just learning and listening to what everyone's got. And I did talk with our health center CEO about, what we're going to be doing moving forward in my role, and Medicaid managed care, where she's like, that's where you're going to be a big helper to us.
Okay, great. Well, thank you so much for hopping in.
Leah, just one thing,
ahead.
Leah. This is Marcella from CSH. Just wanted to make one quick recommendation. There are 4 primary social determinants of health topic areas that are important to North Carolina's Medicaid waiver. One of which is housing, near and dear to my heart. One of which is interpersonal violence. And I'm looking through some of my notes on North Carolina, and I'll try to find and send you what the other 2. The more you align what your health center is gathering data on and who they're who they're gathering that data from with some of those state priorities, the easier I think some of those processes you will be going through. I think transportation is a 3rd, and a 4th may be food insecurity, but don't quote me on those last 2. I do want to find my notes. And that's a good example for other health centers as well, what your state priorities are, how you figure out that information, and then align as much as possible. I hear, Ruben, the great work you're doing and the information you're gathering. I hear it from other people as well, being able to put what you're finding in front of people, data you're pulling from the Prepare tool or other places, and make what you're seeing in your community a state priority. I think this is both a bottom up and a top down process. Just a couple thoughts.
This is Michelle Jester with NAC. That is correct, Marcella, and actually I'm trying to get the North Carolina PCA to speak at our last webinar at the end of the month. They're working out some scheduling things because they'll also be at a Medicaid meeting on that day. But because of the experience of the PCA and a lot of health centers in North Carolina collecting data on social determinants, and it happened to be Prepare, the PCA really was able to have a seat at the table and be a leader in their state to help inform the Medicaid 1115 waiver that helped develop the statewide social determinants tool and the resulting activities and reporting requirements. And so as a result, the statewide tool does pull a lot from Prepare. So just again, by starting social determinants work in your state, you can hence then become leaders in your state to help really inform policy and practice that's going on.
Well said, Michelle. Thank you for that. And we're going to do, I think, one more sort of round to hear from folks if they have questions, comments. Any other takers? Marcella, do you want to
Yeah.
Sure. Let me jump in and talk a little bit about next week. So we have two presenters coming for next week. They are Dr. Rafael Amakusa from Aetna. He's a managed care CMO for managed care in California. And he's going to be talking about the implementation of the health homes procedure. So if we go back to that great slide that Julie gave us, the third one, talking about health homes, he's going to talk about how that's being implemented in California and some of their SDOH priority areas and how they're aligning that work. And then the second presenter is Andrew Grimm and Matthew Malika from Colorado Coalition for the Homeless. They are working on both they have both an FQHC and a large supported housing portfolio, et cetera. And so they're going to be talking about the intersections of housing in there. Our speaker, we lost our original speaker on transportation from, there's that slide. That's great. So if you look at the Medicaid waiver demonstrations, the primary care health homes, that's what we're going to hear next week on that one. And then, Jen, if you want to go back to the others. And then our transportation speaker, unfortunately, fell through. And so we are both looking for some other possibilities, but also really appreciate and grateful Amy and Jenna coming in and talking about their expansion journey, and also helping and looking for at least one more volunteer from that group. So we appreciate that dialogue, but we're going to get some real life examples on how those sectors intersect. The Colorado folks in particular, very interesting how the supportive housing and the FQHC work together. In that example, they are both providers. We are seeing other examples in other communities where it's an FQHC who's looking to develop, that's often commonly more in a rural community, or whether there's more formal partnerships between supportive housing providers and FQHCs so that each can address what the other does so well. So yeah, that's it for me, Leah.
Great. All right, let's see. Do we have any more comments, questions coming out here? I can see, Michelle, you were sharing with Ruben there, and maybe we can revisit that and also take it to Slack. But anything else you want to say, Michelle, in terms of your share with Ruben? Because we have a couple of minutes here, even if we do get an early dismissal.
Sure. Yeah, I wanted to make sure everyone had an opportunity to ask their questions or provide comments. But Ruben, towards the end of your presentation, and thanks so much for doing that. That was great to hear your progress. You had posed a question around being interested in learning more about how others came to the decision to focus on high-risk populations. And I would say where we sit at the national level, at the National Association of Community Health Centers, we've definitely seen that to be a trend. I think especially when you first start out with social determinants, it's great to have a population of focus so that you can start small. And in selecting your population of focus, that also then helps determine what workflow that is used. So some health centers may choose to just focus on high-risk patients, so whether they're defining those as patients who have comorbidities, or those who are seeing a chronic disease management team, or those who see a care coordinator. That's a common population of focus to choose. And therefore, if you're choosing that, then maybe you would use your chronic disease management team or your care coordinators to then also administer Prepare. That's a great way to start kind of integrating your social determinants data to influence what that care team is doing in regards to coming up with more individualized treatment plans that take their socioeconomic situations into context. Other health centers may have decided to choose patients that see a behavioral health team. So again, then maybe you would choose your behavioral health staff to administer Prepare. Maybe they're doing it in conjunction with Expert, or maybe in conjunction with ACE, the Adverse Childhood Experience Survey, or with the Patient Activation Measure. So I think there's a lot of ways to potentially align your population of focus with your workflow model that's also then aligning to similar work that your various staff may be doing. So hope that's helpful.
Very helpful. Thanks, Michelle.
Sure.
Great. Okay, friends, it looks like we're coming up on the end of questions. I don't see anything coming up in the chat. And I think, Marcella, you have one more slide to wrap it up, and we are going to want your, all of you to, we're going to look for a QI improvement on the people who participate in the survey. So, Marcella, you want to walk them through the homework? And then
Sure.
We'll hit the link to the survey and wrap.
Sure, exactly. Thanks, Michelle. Thanks, Ellen. Everybody, I think one of the pieces that's always really clear to me when I get in the social determinants of health space is that how much the partnerships of health centers bring so much resources, so much knowledge, so much, depth and history in their community, but there are other partners that they need to bring to that. So the homework questions for this week are really just to spur your thinking about who are some of those partners. So what are other community initiatives that are active in your food communities? Is there work happening around ending homelessness, around food insecurity, around social isolation? I picked these 3 examples because they're not 3 that you immediately think and say, this is something a health center should be involved in. If we had picked sort of, diabetes issues or infant mortality, it's like, of course, the health centers are there at the first wave and everybody realizes that. But these are 3 that I think health centers can have an impact on and can also understand sort of what work is being done in the community and build your networks to be able to make those referrals, to make those engagements, and to build those partnerships. The second question moves on from there. What's the role of health centers in addressing these issues? How can you get involved in all levels? What portions of this broader issue is your health center uniquely positioned to address? So think about that. And then what are the health priorities for the payers in your community? Ellen, you raised and asked questions again about who's working with managed care on that. What are the priorities there? And if folks aren't sure, let's discuss and figure out how you learn that information. Maybe that aligns with the work your health center wants to do. Maybe it aligns with your strategic plan or other SDOH initiatives you have. Maybe it doesn't, and you need a dialogue with the managed care company about why they need to be concerned about the things that your health center is concerned about in order to improve health in your community, but let's think about that in both ways. Post answers to Slack or submit the questions to Janice by next Wednesday of next week, and then we'll be able to process them for next Thursday's conversation. And then just an FYI, Janice is out for a couple of days, so our email is going to come out on Tuesday, April 16th. So if you're all waiting for your Monday afternoon email from Janice, don't wait too long. It's going to come out on Tuesday. And with that, I believe, Michelle, Ellen, any last questions? Other than the thank you to HRSA for all of their support and allowing us to do this. Well, I think, and take it away, please complete the survey, and we'll put it in the chat. There you go. And we'll be sending it out if we don't hear from you on Tuesday. And I think with that, we're going to give you the last 3 minutes of your afternoon, and we'll see you all next week. Thanks, everybody. Have a great weekend. Thanks, everybody.
Okay, take care.
Thank you.
Thanks.